Good afternoon, everyone. Hopefully you can hear me okay. Welcome to today's special Hopkins Hour online seminar to mark and celebrate the International Day of People with Disability, which was, of course, on Tuesday, and Human Rights Week is also this week in Queensland. I'd like to acknowledge the traditional owners of the land on which we meet virtually today. My office is on the land of the Geraghty and Turrbal people, and I would like to pay my respect to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people. And we encourage all attendees to research and connect with the traditional owners of the land on which they live and work. The title of today's Hopkins Hour is Understanding the Lived Experience of People with Spinal Cord Injury, an update from the Australian arm of the International Spinal Cord Injury Community Survey Project, also known as Aus-InSCI. We'd like to extend a warm welcome to all Hopkins members, partners, collaborators who are joining with us today. For those of you who don't know me, I'm Tim Geraghty, Director of the Hopkins Centre and Senior Staff Specialist in the Spinal Injuries Unit at Princess Alexandra Hospital, and I'll be the chair of today's seminar, which will include 4 presentations and a panel discussion and question and answer session at the end. Before we get started, just a couple of housekeeping items. Obviously, sometimes there may be issues with internet connections or other things where you are. If you experience technical difficulties, please feel free to put a question in the chat via the toolbar at the top of your screen, and one of our events team will try and assist you. If needed, you can leave the team's event platform at any time and return to it without losing your place. For those who are hearing impaired, closed captioning is available via the top level toolbar of your Teams platform. Today we'll be holding questions until the panel discussion at the end, unless the presenters finish their talks very early, when we might have a chance to have a question or two then. But I think we'll be holding till the end. We should have about 15 minutes at the end for questions. But please feel free to ask questions at any time throughout the event by typing the question into the chat box. And we'll be moderating and keeping an eye on all those questions. At the end, we'll try and answer as many questions as we can during the panel discussion. If there are things that we don't get to, we'll try and provide an answer via email after we finish today. If you have trouble with the chat box, when we get to the panel discussion at the end, we will open up to live questions as well. And if you can raise your hand during that time, if there's a question that you haven't been able to get into the chat. It's my pleasure to introduce today's speakers. Initially, Samantha Borg, who's the research assistant at Hopkins Centre at Griffith and a PhD candidate at Queensland University of Technology. And Sam will be talking about health service use and unmet healthcare needs in spinal cord injury. Annette Kifley, who's a senior research fellow at John Walsh Centre for Rehabilitation Research at University of Sydney. And Annette will be talking on the burden and impact of hidden disability in people with spinal cord injury. And Dr. Camila Oliveira, who's Associate Professor, Discipline of Physiotherapy in the School of Health Sciences at Western Sydney University, and Clinical and Research Advisor for Spinal Cord Injury Australia. And Camila will be talking about physical activity participation in people with spinal cord injury. I'm going to get things started with a brief introduction to provide some background and context to the Australian arm of the International Spinal Cord Injury Community Survey Study. And all of the speakers today are part of the Aus-InSCI team, which is led by James Middleton and Moet Aurora in Sydney, and has a large team of investigators throughout Australia. Okay, I will share my presentation. Okay, hopefully everyone is seeing that okay. So, an introduction to the Australian arm of the International Spinal Cord Injury Community Survey, understanding the lived experience of people with spinal cord injury. So as we know, people with spinal cord injury and those around them experience profound and long-lasting changes in many life domains after the injury. There's been a lack of large population-based Australian studies examining the lived experience and identifying priority problems and lifelong needs for people with spinal cord injury. And this study goes some way to addressing that. We're interested in understanding the unique and complex interactions between the person with spinal cord injury, their environment, and participation in the community. And we particularly want to understand the impact of these factors on health and functioning to inform policy and practice changes. So what are the research questions? What's the purpose of the Aus-InSCI survey? So we want to look at the determinants of functioning, health, and well-being for people with spinal cord injury. And from a lived experience perspective, look at what are the most common problems and needs that people with spinal cord injury experience along the continuum of care. And it's taking a learning health systems approach to inform appropriate responses for things like targeting improved clinical practice and delivery of services, community engagement to empower individuals with spinal cord injury and their families, and to promote advocacy and policy dialogue to enable change, including legislation, in regulation, funding, and support. So the areas that that the study's interested in align with the ICF and include health and well-being, activities and participation, environmental factors, psychosocial outcomes, and quality of life. On the right there's an overview. So this data comes from the Aus-InSCI survey that was conducted in 2018-19. People needed to be aged over 18 to participate and to have been living in the community for at least 1 year post-spinal cord injury. There were 9 data custodians around Australia from Queensland, New South Wales, Victoria, and South Australia. There was a 27% response rate and a total of 1,579 people responded in Australia. This was part of a larger international study, which included 22 other countries. And the sample was considered a representative sample with good generalizability. Just to look a bit more closely at the Australian responders. So in that first survey, Australia recruited the second largest a number of respondents of the 22 countries. And you can see the distribution of responders there. New South Wales has had the largest cohort, followed by Queensland. So the survey questionnaire that was sent out was quite large, and it covered the domains that we talked about previously: body functions, activity participation, environment, personal factors, injury characteristics, and quality of life. And then most countries had their own national data questions as well. And in Australia, we had an extra 68 questions that we specifically asked. And those included sub-additional demographic questions, questions around satisfaction with health providers, pain, physical activity, skin breakdown, fatigue, social integration, perceived injustice, and sleep quality. So that was the 2018-19 survey, and that's the data that we'll be talking about today. The next international survey is currently underway. It commenced last year. And in Australia, it's continuing 2024 and into 2025. We'll be continuing to distribute and receive survey responses. In this next version, there'll be 33 participating countries. And I also just wanted to mention that we are also running a translation project. So obviously having all of this huge amount of data is great, but ultimately what we want to do is impact practice and policy and improve quality of life and outcomes for people with spinal cord injury. And we've been lucky enough to get some funding from NISQ, which will allow us to do a specific translation project, which will run, it's just commenced recently and will run for 3 years. If you'd like some more information about any of that, there's quite a lot of information on our Hopkins webpage, and I encourage you to have a look at that. There's a big team involved in this, and I won't go through all of these people, but a large number of partners and a very large number of research participants. Thank you all very much, and I will hand over to Sam Borg now, who will continue with the presentation, and she'll be looking at health service use and unmet need.
Thank you, everyone. So as Tim mentioned, I'm talking about, sorry, I'm just checking I'm unmuted myself. Is the mouse on this backwards? So looking at unmet healthcare needs and health service, and this is from the Australian responders of Aus-InSCI. So we know that appropriate and timely lifetime access to healthcare is essential after a spinal cord injury. We also know that unmet healthcare needs among people with spinal cord injury are quite common. And there is evidence that poor experiences with healthcare providers can be a barrier to health-seeking behaviour. So we hypothesise that there would be a relationship between poor care experiences and people with unmet healthcare needs. This study used quite a large group of the data. So we had 3 aims. Firstly, to describe health service use, unmet needs, and satisfaction with healthcare services in the past 12 months. Secondly, to look at associations between those care experiences and the unmet healthcare needs, but more generally to explore factors that are associated with different types of health service use, different types of health practitioners. So I won't go over our study design. Tim's already covered that, but this is some demographics for our Australian responders. So 73% were males. The median age for our responders was 59 years. 59% were married or in a partnership at the time of responding, and the majority of participants lived in a metropolitan area. For their injury characteristics, this was a relatively longer cohort with spinal cord injury, with a median time since injury of 13 years. Incomplete injuries were more common, and of course, those traumatic onsets were also more common. So for aim 1, we looked at healthcare use in the past 12 months. The most used healthcare providers were general practitioners and pharmacists, but we saw some healthcare providers that we would perhaps expect to see utilised more, that were used by a much fewer proportion of the population. So for example, psychologists were only seen by 12%, dietitians by 10%, and social workers by 9%. And concerningly, we saw 5% of our participants who hadn't seen any healthcare providers in the previous 12 months. We also looked at who people considered to be their main contact provider for spinal cord injury problems. The majority reported general practitioners, followed by spinal specialists or other types of specialists, but some did have other types of contacts, so outside of this space, allied health or often other healthcare providers. And nearly half of our cohort was hospitalised in the past year, and this was defined as being admitted to a hospital or a similar medical facility for at least 1 night. So in terms of unmet healthcare needs, there were 17% who reported having health needs that weren't able to be met. This was primarily due to the cost of the service, but the next most frequent reasons were service unavailability, inadequate provider skills, and people who perhaps thought they were not sick enough to seek medical care. But what's particularly important here as well is that people often reported multiple reasons that they had unmet healthcare needs, not just a singular reason. For satisfaction with health services, the survey asked specifically about general practitioners, statewide health services, and local hospitals. So satisfaction across the board was relatively high. And in terms of dissatisfaction, it was actually highest at 11% for our statewide spinal services. This is our modelling for unmet healthcare needs, and I promise I won't make you read that graph. But there were a couple of factors that where people were more likely to report unmet needs. And in this instance, people who'd had bad experiences of being treated respectfully by their healthcare provider reported more unmet needs. Also females, those with a higher functional capacity, and those with more secondary conditions. People were less likely to report unmet needs if they were older or had complete paraplegia. So for the third aim, we also looked at factors that were associated with 4 different providers, so general practitioners, allied health practitioners, medical specialists, so this included any type of specialist from urologists and so on. And the last one was related to rehab or spinal cord injury specialists specifically. So there are a few variables that were important across multiple of the models. So those who received daily help were more likely to have seen nearly all of the healthcare providers, so allied health practitioners, medical and spinal cord injury specialists. Higher education was also strongly associated with having been more likely to see, again, nearly all of the healthcare providers. Those with a higher functional status were less likely to have seen any healthcare provider. And the final factor that was important across multiple of our modelling was time since injury. They were more likely to have seen a general practitioner, but less likely to have seen any of the allied health practitioners or the rehab or spinal specialists. So unmet needs in this population were reported by almost 1 in 5. This is perhaps not as high as people were anticipating, but compared to the 22 countries who responded in 2018-2019 period, Australia was the 8th highest country to report unmet needs. Some instances of the experiences with healthcare providers were associated with unmet needs. So again, highlighting the importance of people's experience with healthcare providers and having positive and strong relationships. There was some evidence of underutilization of healthcare providers, particularly compared to some other spinal cohorts. So for example, we saw dietitians used by 10% and psychologists by 12%, and even in our cohort, dentists, who were seen by 39%, was a lot lower than what we see in other cohorts around the world. There were a number of different reasons for unmet healthcare needs. These are particularly healthcare costs, but we can't diminish the importance of responses that identified inadequate provider skills or equipment, and again, the treatment with healthcare professionals. So there are a number of implications for practice. Given the importance of GPs and them being the highest healthcare provider who was used, there's evidence that suggests we need to have an enhanced collaboration between our primary care and our specialist spinal cord injury practitioners to be able to build knowledge and capacity in that primary care space and enhance our healthcare infrastructure and access. It also highlights promoting the adoption of person-centered models to really be able to overcome some of those negative experiences that people had with their healthcare providers, and where we saw higher rates of dissatisfaction among specifically the statewide services. And lastly, it's about, as I'm sure many of you are aware, ensuring provision of the right service at the right time and in the right place by the right provider to be able to deliver more personalised rehabilitation pathways. This paper is now online and is open access and available if you scan the QR code. And as Tim reiterated, this is a part of a very large team that supported this project and contributed. So obviously acknowledge both our contributing partners and the other staff involved. And I will stop sharing now and I will hand over to Annette. Who else wants to do that? I'm on Tim's computer and it's throwing me for a bit of a loop. I'm sorry. I'll hand back over to Tim. Just stop sharing.
Okay, over to you, Annette.
I'll get going. So I'm Annette Kifley from the John Moore Centre for Rehabilitation Research, and I'm going to talk about the burden and impact of hidden disability in people with spinal cord injury. I'll introduce what hidden disability due to spinal cord injury is all about. Then I'll show you some relevant Australian research findings from Aus-InSCI, and then discuss the impact of hidden disability a bit further using findings from other qualitative studies. Let me know if that's not advancing. It looks fine to me. So hidden disability, sometimes it's also called invisible disability, and it refers to disability that is not readily apparent to outside observers, but that limits a person's activities, sometimes severely. Sometimes hidden disability isn't actually completely invisible, but it's just gone unrecognised, or the impact goes unrecognised. And it can be present with or without more obvious disability. This is an adaptation of some work done by the New Zealand Spinal Trust, which put forward the concept of a disability iceberg in people with spinal cord injury. So above the surface, what an outside observer might readily see is whether a person can move their arms and legs, or whether that's impaired, whether a wheelchair is used, whether a ventilator is used for breathing, whether there's an obvious problem when walking. But most of the impact of a spinal cord injury is not visible above the surface. So below the surface, spinal cord injury can result in a really long list of other issues, which can affect daily life much more profoundly than the obvious disability of needing to use a wheelchair. Problems like pain, fatigue, difficulties in managing bowel and bladder function, muscle tension and spasms, pressure injuries, the psychological and social impacts of the injury and of the disability that results from it, and the additional time and effort needed to go about daily life. And for people who can still walk after spinal cord injury, many of these less visible issues can occur in the absence of any more obvious disability. So I'll move on to some findings from Aus-InSCI now. And I'll start with a preview of some key messages about hidden disability that have come out of our analysis. And then I'll briefly show you some more of the detailed data that lies behind. But firstly, it's common for people with spinal cord injury to have a substantial burden of underlying, potentially hidden problems, regardless of the severity of their injury, and even if they're able to walk around and appear to be fine on the surface. And these hidden disabilities can substantially affect their long-term quality of life, including in people with spinal cord injury who appear to be functioning well and independently. So the well-being of the more functionally independent people cannot be taken for granted. And while injury characteristics and levels of independence drive many aspects of lived experience, in the long run, the key drivers of quality of life after spinal cord injury seem to be problem burdens and psychological and social factors. So on this slide, I want to draw your attention mainly to the last column, looking at the frequency of secondary health problems and activity and participation problems in people who can still walk after spinal cord injury, so in the ambulant subgroup. And notably, there's a really substantial burden of health and activity problems across all of mobility categories, including in people who can still walk in the last column. An average of 7 secondary health conditions for ambulant people, 2 severe to extreme health conditions. Very similar rates of pain and severe to extreme pain as in wheelchair users, 85% for any pain, 45% for severe to extreme pain. A majority with ongoing problems with managing bowel and bladder function, a majority with ongoing difficulties with sleep and with sexual function, and a high proportion with at least some issues, some severe to extreme issues with activity and participation problems. And these are all high priority functional areas that can cause hidden disability, including among people with relatively high levels of functional independence. So looking at quality of life and mental health, quality of life ratings are very similar on average for ambulant people who can walk after spinal cord injury as in people who use self-operated manual wheelchairs. They're somewhat lower in electric wheelchair users, while mental health and vitality ratings were very similar in ambulant people as in electric wheelchair users, both a bit lower than in self-operated manual wheelchair users. So contrary to what people often assume, life as a whole is not necessarily perceived to be better in the eyes of ambulant people with spinal cord injury rather than for wheelchair users. So we then used a statistical technique on the Aus-InSCI data to identify underlying subgroups of people with different patterns of lived experience based on levels of functional independence on one hand and on the burden of problems across the areas of self-efficacy, activities and participation, secondary health problems, and environmental barriers to participation on the other hand. So there are 4 groups with relatively high functional independence shown in the second and third columns, and 3 groups with lower functional independence, which are shown in the 4th column. And as you go down the rows, we've got increasing problem burden. So just to descriptively, among Aus-InSCI participants with high or very high functional independence, roughly a quarter had moderate to high problem burden. So that's the blue circle and comment. By comparison, among Aus-InSCI participants with lower functional independence, roughly 2/3 had moderate to high problem burdens. So that's the grey circle and the grey comment. And looking from the alternative perspective, among Aus-InSCI participants who did have moderate to high problem burdens, roughly half of those people had relatively high functional independence. So now I'm going to look at quality of life. And when we looked further at these subgroups, it was very striking that quality of life ratings reflected problem burden and psychosocial factors much more closely than functional level. So the graph on the left shows SCIM scores for independence in basic ADLs, showing more independent subgroups in lighter grey towards the top and less independent subgroups in darker grey towards the bottom. Problem burdens are low in the 3 groups on the left, high in the 2 groups on the right, and moderate for the 2 groups in the middle. And the graph on the right shows that differences in self-reported quality of life are following the level of problem burden on average, not the level of functional independence. So to see this, look at the gradient from left to right as problem burden is increasing. When we look within an individual level of problem burden and self-efficacy, we found that self-rated quality of life was basically equally high on average in the less and the more functionally independent subgroup. So I won't labour the plots themselves any further, but similarly for mental health and vitality, these also reflected problem burden and psychosocial factors much more closely than they reflected functional level. So these findings provide evidence on Australians living in the community with spinal cord injury that the well-being of ambulant and other more functionally independent people with spinal cord injury can be substantially affected by hidden impairments and disabilities. The key drivers of quality of life in the long run are problem burdens and psychosocial factors rather than the type and severity of the injury. And these findings back up qualitative reports, clinical experience, and consumer lived experiences, which I will briefly touch on now. This slide just shows several qualitative studies that have been published that are focused specifically on lived experience of people who can walk after spinal cord injury or who have cauda equina syndrome, which causes compression of lumbosacral nerve roots and, if it's not resolved quickly enough, possibly long-term neurological damage. But in general, the person can still walk. And these are findings. In the blue, these are just a few quotes that give the flavour of what people in the community with hidden disability due to spinal cord injury can be going through. You know, I can't leave the house. I can't socialise. I'm isolated and I'm scared. Or people think there's something wrong with you, not that you're injured. Or I suffer the same problems as people with paraplegia or quadriplegia. It's just that you can't tell. So people describe feeling invisible, excluded and isolated, that other people, including health practitioners, disability support systems and the community, don't understand their condition. They don't understand the disability that it causes them. They don't understand the impact it's having on their life. They can struggle with eligibility and access to services and supports that they need to adapt to their condition and move forward with life in the community. So the impact and distress caused by hidden disability due to spinal cord injury can be really profound. Okay, and thank you all for listening. This is my final slide, the acknowledgements we've been through before. And now I'll pass on to Camila Oliveira for her talk.
Thank you, Annette. Okay, I'm gonna try to share my slides now. So can you see my slides?
We're seeing your notes page.
Yeah, well. Okay. All good now?
Yep.
Yeah, thanks, Annette. Yeah, good afternoon, everyone. So I am Camila, physiotherapist, an academic here, currently at the Western Sydney University. I just moved last week from UTS, so I'm in the transition period. So some of the slides still gonna have the UTS symbol in because I'm doing the transition phase and the work was mostly done during my time at UTS. So my group looked into leisure time physical activity participation in people with SCI. So we looked into the LTPA, which is the acronym that we use for leisure time physical activity in the Aus-InSCI survey. So before I start, I'd also like to acknowledge the traditional custodians of the lands that I'm today in, which is the Wangal people of the Eora Nation, and pay my respect to the elders past, present, and emerging. So I also need to acknowledge that this is the work that I'm going to present today is the work of my two PhD students. So Dr. Paul Watson, who graduated recently from the University of Sydney, and Ms. Laura Stendel, who is at the very final stage. So her thesis is being assessed as we speak from the University of Technology, Sydney. So it's a combination of their two PhD theses. And this work has been supported by Spinal Cord Injuries Australia. So what I'm going to present on today, I'm going to talk about the characteristics of leisure time physical activity in people with spinal cord injuries in Australia. We're also going to have a look into specific aspects of physical activity participation in the middle age and older individuals with SCI, which is often an understudied population. And we're going to look into some of the associations between physical activity participation and health outcomes. So why have we had a look into leisure time physical activity and what was our definition of leisure time physical activity? So we wanted to understand what people are doing after rehabilitation. So we looked into leisure time physical activity. Our definition was any physical activity that people do in their spare time, such as playing sports, walking or wheeling, going to the gym, and other recreational exercise. So we excluded any rehabilitation sort of exercise or FES, such as functional electrical stimulation. So we were very interested in our studies into looking into the intensity of leisure time physical activity, LTPA, that people were performing. So we looked into their participation to mild, moderate, and vigorous physical activity, mainly because the intensity of physical activity is related to health outcomes. So we also looked into strength activities and aerobic activities because this is how the physical activity guidelines are defined. So we know that in Australia, we have a strong statement and strong positioning of exercise sports science in Australia on the recommendations of exercise for people with a spinal cord injury. Similarly, the World Health Organization has specific guidelines for physical activity in order to achieve cardiovascular fitness and cardiovascular protection. Specific for people with disabilities, not specific to spinal cord injuries, but specific to people with disability, which is very similar to the recommendation for the able-bodied population, which is at least 150 to 300 minutes of moderate intensity aerobic physical activity. And then we also have the physical activity guidelines specific for people with SCI, which was developed by the Canadian group, which recommends for aerobic activity at least 20 minutes twice a week of moderate to vigorous intensity, and strength training activity at least 3 sets 10 reps twice a week for each major muscle group that are still innervated. So this is just the starting recommendations to achieve cardiovascular fitness and to actually achieve improvements in cardiometabolic health and protect from cardiometabolic diseases. The recommendation is a little bit higher. So 30 minutes of aerobic activity 3 times a week, moderate to vigorous intensity, and strength training, maintaining the similar recommendation from the baseline levels. So we use the Canadian physical activity recommendations guidelines, which is specific for spinal cord injuries in our studies. So the first study where we use the Aus-InSCI physical activity data has been published already. And we looked into the characteristics of physical activity in people with SCI with 2 main aims. So we wanted to investigate the volume that people with SCI were participating in terms of LTPA, and the degree of LTPA, and to see if they were meeting the physical activity guideline recommendations. So our second aim was to look into, to analyze the effects of and see if there were any relationships between socio-demographic and injury characteristics on volumes of physical activity and their adherence to physical activity guidelines. So we use the Aus-InSCI data, and we were able to include 1,579 individuals in our sample. And we looked into the LTPA participation component of the survey, which was by using the modified PASPID, which is a recall questionnaire that produces a total score in minutes per week of physical activity participation. We only used data that was related to leisure time physical activity, data that was related to ADL, so activity and movement during activities of daily living were excluded. So similar with the demographics that has been already described in the previous presentation today, most of our sample size was formed by males. Our age range was our mean age was 57 years old, with a mean time since injury of 17 years. Majority of the individuals had a traumatic injury, and majority half of our sample were in a partnership relationship. Almost 30% were employed, and almost half of our sample were ambulating using a wheelchair. So what have we found? We found that 42% of people with SCI were sedentary in Australia, which is quite an alarming number. 58% of people were physically active, but when we look into the physically active population, only 22% were exercising enough to achieve the recommendations of the physical activity guidelines. And when you look at the overall sample, only 30% were achieving the guideline recommendation. So in summary, 55% of the Australian adults do not meet the physical activity guidelines, and 72% of Australians with a disability do not meet the physical activity guidelines. So we see that there is, comparing the overall population, where we have 55% of people not meeting the physical activity guidelines, people with SCI are doing much worse. And 87% of the Australians with a spinal cord, 72% of Australians with a disability and 87% of Australians with a spinal cord injury do not achieve the recommendations of the guidelines. How does that compare to other countries? It's very similar when you look at the data from other countries that looked into physical activity participation in SCI. The only different one is Sweden, where actually 49% met the physical activity guidelines. So they're doing very well. And when we look into associations between physical activity participation and injury characteristics, male perform 40% more physical activity than females. Younger people, beyond the age gap of 18 to 30-year-olds, perform 32% more physical activity than other ages. So as people age, there is a decline in physical activity participation. So that's one of the reasons why we wanted to do a deep dive and look specifically in the middle and older people in the following studies. So people with traumatic SCI perform 47% more physical activity than non-traumatic. the degree of injury only affected the participation on strength training physical activity, but not so much in general cardiovascular physical activity. Gender, cause of injury, and method of ambulation and age were weak predictor of participation in total physical activity. An important finding that the study showed was that individuals with traumatic injury are 70% more likely to be on exercise and 1.8% more likely to adhere to physical activity guidelines when compared to non-traumatic injuries. So I guess it's no news that people with SCI are at a greater risk of cardiometabolic diseases such as hypertension, hyperlipidemia, and also musculoskeletal injuries, psychological and mental health impairments, and they are more likely to have more hospitalizations in life, so which leads to indirect costs of SCI per year of approximately $80,000. So why this data is important is because physical activity has shown to reduce all cause of mortality risk in people with SCI, reduces hospitalization rates, and reduce the health risks associated with prolonged sitting. Also can improve mental health and psychological health, reduce risks of pneumonia, and in the US, they looked into the financial benefits of participating in routine physical activity, and they saw a reduction of lifetime costs from approximately $290,000 to $435,000 American dollars. So increasing and promoting physical activity in this population can have a huge impact not only on individuals' health, and by health I mean all aspects of health, including mental health, and also decrease the burden to the health system. So in conclusion, healthful physical activity volume is very low for people with an SCI in Australia. So 42% of people are sedentary. Only 1 in 6 people met the SCI specific physical activity guidelines, and only 1 in 4 people who were active actually met the guidelines. So even the ones that are exercising a lot of the time are not doing in a healthy volume and intensity. So specific attention should be given to females, older individuals, those who had a non-traumatic injury, and those who require more assistance to ambulate, because these are the groups that are exercising less. And social demographic and injury characteristics didn't seem to influence physical activity volume. Other potentially modifiable factors might predict physical activity volume and need to be further investigated. So that was the work of Dr. Paul Watson in his PhD, but as I said before, we wanted to have a deeper look on what was happening with the aging population with SCI, because we know that the profile of spinal cord injury is changing, so we have more injuries occurring in those over 45 years of age. We know that the people with SCI age more rapidly due to the cardiometabolic and autonomic changes, and that how lack of physical activity can accelerate this metabolic aging. And we know from previous research that they are the most deconditioning group in the disability group. We decided on the cutoff of 45 years of age for our aging people with SCI, because we based that cutoff on larger studies, larger cohort studies in the able-bodied population, like the 45 and up study here in Australia, the Rotterdam study in the Netherlands, and the Canadian longitudinal study on aging. So that arm of the InSCI data, so initially we wanted to look into leisure time physical activity participation, similar to what we did with the whole Aus-InSCI data. So I wanted to describe the amount of LTPA in this older population and explore the associations between LTPA volume and participants' characteristics. So we excluded people from the bigger Aus-InSCI data sets that were younger than 45 years old. And then, so we ended up with a very big sample size still, so we excluded around 300 people only. So we couldn't find that many differences between the two subpopulations, between the larger in the subpopulation. So the mean age in that sample was 62 years of age, and the mean time since injuries was 18 years. So again, we had more males in our sample size, more people with paraplegia, traumatic injuries, and that were in a relationship partnership. So when we look at the levels of participation of physical activity, when we look into total weekly LTPA, so 44% of the participants, that includes all intensities and modalities of LTPA, so 44% had no participation, so participated in 0 minutes per week in total LTPA. However, but the mean was 197 minutes per week of participation, which sounds really good, but what we saw in our data is that the data was very skewed. So we can't rely on that mean as much, because we had people that reported that they completed like enormous amounts of participation in physical activity, which is actually one of the limitations of the study, the reporting, the accuracy of the reporting, but a lot of people reporting 0 minutes per week in participation of physical activity. When we look into moderate to heavy, 75% reported no participation in moderate to heavy, and this is the intensity of physical activity that actually can produce general health benefits, with a mean of only 62 minutes per week. And when we look, and again, the median was 0 minutes per week. When we look at strength training, 52% had no participation in strength training, with a mean of 63, and again, an interquartile range of 0 minutes per week. When we look into the associations with injury characteristics, so very similar to the general Aus-InSCI data, so people with non-traumatic and longer time since injury and being female were indicators of lower participation in total physical activity and strength training physical activity. And when we look to moderate to heavy, people having non-traumatic injuries and older were having less participation in physical activity. So this is the spline analysis that we've done, the spline graphs for time since injury. So as you can see, there was a lot of variability on the data. So you can see that the dots are quite scattered, especially when you look into total time of physical activities, which is the pink graph on the left-hand side. And you see that although there was an association, the lines are quite flat, which indicate that that association might not be clinically significant. So although as people age, they tend to exercise less, the strength of the association wasn't that relevant. So what we concluded that a large population, 44% of the aging people with SCI participated in no physical activity at all, leisure time physical activity at all. 75% did not engage in moderate to heavy, which is the healthy levels of participation in physical activity, and 50 didn't engage in strength training. And there was no evidence that suggested a significant association between, a clinically significant association between participation in moderate to heavy and strength training with time since injury. But this study raises the importance of LTPA promotion strategies to maybe happen early in rehab, to allow for continuous participation after discharge, and to target towards aging women, non-traumatic and non-traumatic causes of injury. So based on this population, the subpopulation, the older population data, we also wanted to look into possible associations of participation in physical activity and other domains in the Aus-InSCI survey. So we looked into the associations between activity and participation problems in the community, satisfaction with life, quality of life, and perceived health in the older population. And we saw that although there were associations, again, they weren't very strong. So when we look into volume and intensity of LTPA, there wasn't a clinically relevant impact on activity and participation problems in the older population. And when you looked into quality of life, perceived health, and satisfaction with life in adults aging with SCI, that might be supported through the uptake of LTPA, but particularly to moderate to heavy intensity. So reinforcing the concept that intensity is important when thinking about the benefits of LTPA. So then where did we go from that? So that data the analysis of the Aus-InSCI data brought to our attention how little people with SCI were exercising in the community and the potential detriments of those low levels of physical activity. So we had a further look, and we've done a few qualitative studies to try to understand better those physical activity behaviors in this population. So we wanted to understand what are the physical activity motives and perceived gains for individuals with SCI, and we compared the younger and the older population with SCI, and we saw that for younger people with an SCI, a lot of the time they're exercising because they want those fitness and that maybe more aesthetic sort of benefits of exercise. But when you look into the older population, one of the motivators is the social interactions that people get from participating in physical activity. For example, going to their community leisure center for a swim and then have a coffee with their friends or with the family after. So those seem to be strong facilitators for physical activity engagement. We looked into barriers, and we looked into specifically in the middle-aged and older people, like that those psychological benefits of exercise. So then what is next? So now that we know what the amount of physical activity and some of the potential enablers and barriers to physical activity, so we're planning our next steps in terms of research in this area. So we have already came up with a couple of policy briefings, which we're going to publish in the website for Spinal Cord Injuries Australia. So because Spinal Cord Injuries Australia has a strong individual and systemic advocacy team, so we're going to make that available for the SCIA members. To hopefully support knowledge translation to policymakers. We're planning a couple of implementation studies. So based on the findings, mainly of the qualitative studies, we're proposing some ecological changes to facilitate access to physical activity in the community, because one of the things that we found out in our studies is not the physical barriers that are the main barriers
Camila.
for... Yep.
Sorry to interrupt. We might just need to finish so that we've got time for a couple of questions.
Sorry, team. Yeah, so we're looking into how we can promote better environments for people with physical activity for people with spinal cord injury to exercise, and how can we implement the physical activity guidelines in the spinal units and in community settings. And a strong component in our studies that we're planning at the moment is to have that co-design with people with lived experience. Sorry, team, that was me.
Thanks very much. Thanks very much, Camila. And if you could thank all our speakers today. We've probably got time for one or two questions. I'm not sure that there is anything in the chat at the moment as far as questions, but please, if you'd like to ask a question now, raise your hand. So I might just ask one for Camila. So Camila, obviously we know that it's often very difficult for people with spinal cord injury to exercise for a whole range of reasons. How can we make that easier, do you think?
Yeah, so it was very interesting in our qualitative studies that we were thinking about coming up with strategies, like an exercise app, or something that people could exercise from home to facilitate engagement, but actually people want to exercise in the community. That's what we found when we interviewed our participants. So they want to access bushwalks, community leisure centers. So I think we need an ecological change. We need to provide better structures in the community, like more disability welcoming possibilities of exercise and such access to information, where they can have like a accessible bushwalk, or having people trained in community leisure centers on how help people transferring, because we see that a lot of the time those community gyms, they are accessible, but there's not many people with actually disability attending those places. So I guess more welcoming spaces are needed.
Great. Thank you very much. I'm sorry we've probably run out of time today. But if anyone has any questions that they think of, we'd be very happy for you to send them through via email, and we'll be happy to answer them. If you can thank all of our speakers today again, Sam Borg, Annette Kifley, and Camila of Oliveira, for their excellent presentations. Thank you very much. And thank you all for attending today's Hopkins Hour. We really appreciate everyone making the time to join us, and it's been great to have everyone here. We hope you found the session informative, and we encourage you to reflect more on the value and the importance of International Day for People with Disabilities and Human Rights Week. If you'd like to get in touch with any of the presenters, please contact us through the Hopkins Centre, and we can provide you with their contact details. This is the last Hopkins Hour event for 2024, but we look forward to being back with you early in 2025. And also keep an eye out for our final Hopkins Wrap e-newsletter, which will be coming out next week, which will be jam-packed final one for the year. Thank you all again. We hope you have a happy and safe holiday period, and we look forward to seeing everyone again in 2025. Thanks, everyone.